Good afternoon, everyone, and welcome to the South to South Learning Network Link and Learn on Adolescent Health Indabas. This is being hosted by Zambia, and I am going to be your chair for this session. My name is Tina Chisenga. I'm with the Ministry of Health, and I am the Assistant Director for Disease Control at the Ministry of Health. We have a very packed session for you today, and I'm hoping that through this discussion, you're going to learn quite a lot of what Zambia has done as it pertains to adolescent health indabas. For all of us who are on the southern part of Africa, we know what an indaba is. It's a meeting that brings together people from all parts of society or the community to discuss a very important or serious topic. So for us as Ministry of Health in Zambia, we thought that because of the issues that are pertaining to adolescents, particularly when it comes to HIV, it was important for us to bring together different adolescents from across the country to come and discuss specific topics that relate to prevention of HIV. So as part of our agenda, we're going to give you a background. We'll give you also an insight into the regional adolescent health indabas, and we'll have a discussion and Q&A thereafter. And of course, in the closing, we'll have a way of seeing what key takeaways we can take from the messaging that you're going to get from Zambia today. So with that, I would like to welcome you again, and I will hand you to Dr. Chimika Piri, who's going to take us through the background of Zambia's epidemic and why adolescent indabas. Over to you, Dr. Piri.
Thank you, Dr. Senga, and hello, everyone. So just switched on my video, but I'll keep it off because of the bandwidth. So I'll take you through in terms of the background to what led to Zambia to have the indabas. My name is Chimika Piri from Ministry of Health. I'm anchoring the HIV prevention program. Next slide. So in terms of the overview, a number of surveys, a number of reports showed that we had burden of HIV among the adolescents and young people. For example, by then we still noticed that in Africa, HIV AIDS was still the leading cause of death, particularly among the young people. And it was actually globally, we appreciated that it was the second leading cause of mortality among this age group. From Zambia, it was reported that as Zambia, we record on an annual basis around 28,000 new cases of HIV. This is for adult population. In this case, the individuals above age 15 and above. So in terms of the FIA report for 2021, that was conducted in 2021, Zambia stands at 11% in terms of HIV prevalence. Again, this is for adults, for the age group 15 and above. You notice that we didn't have, this survey did not include the children or the pediatrics 14 and below, but we know that for the adolescents, usually we look at the age 10 to 19, but for the HIV program, many times we focus for those 15 to 24 for the adolescents and young people. So from the 28,000, we noted that Zambia reported that on an annual basis, on average, about 14,000 of the new cases from the adolescents and young people. And in terms of the burden between the urban and the rural, from the Zambia Demographic and Health Survey, it showed that the the burden is more in urban areas compared to rural areas. I'm sure this may be comparable to other countries in the region because of some economic activities that may drive the HIV transmission in the urban areas. This could be one of the explanations. So on my right on the slide, you see a picture of map of Zambia depicting various prevalences of HIV among the 10 provinces. But on the national scale, Zambia stands at 11% in terms of prevalence of HIV. And you could see the darker provinces, these are the ones like for Lusaka, which is the capital city. And then we have the Western provinces and the Copper Belt provinces. These have high economic activities. Next slide. Okay, so with that in mind, further information that we noted, actually that had put the adolescents and young people to be still a vulnerable group to HIV acquisition. For example, as I earlier indicated, Zambia indicated that about 38% of the annual new infections are actually coming from the adolescents and young people. And more so, we see that the adolescent girls, or rather young adolescent girls aged between 15 to 19, from the Zambia Demographic Health Survey showed that they were likely to report having received HIV test in the past 12 months before the survey was done, compared to the slightly older women aged 20 to 24. Further, it was noted that in terms of the comprehension, in terms of the knowledge for comprehensive HIV prevention, the same age group, the 15 to 24, was noted to have low knowledge about the comprehensive HIV prevention and just generally information around the HIV. So this, in addition to other things that I've mentioned, made these adolescents and young people vulnerable to HIV. In addition, in terms of perception, this age group, the adolescents and young people, seemed to have low perception in terms of for them to be at risk of HIV infection. And this could have been, could explain why many of this age group are involved in unsafer sex, which accounted for the common roots of HIV infection, particularly for the adolescent young girls, adolescent girls and young women. Furthermore, it was noted that there was limited access to HIV and as well as sexual and reproductive health in terms of the high impact services for adolescent and young women. And this, as the ministry, remained a key issue. And I think quite a number of efforts are being put in place to ensure that we improve equity to access to the HIV information and also access to sexual and reproductive health in terms of the high impact services. So we also included just a programmatic analysis. This is information from our DHIS tool and also the DISA based on the 2023 program data. In terms of the performance for the adolescents and young people, those that are on that are living with HIV and receiving ART. So compared to the adult population, which seemingly has done well in achieving the 95 UNA's target, the adolescents and young people still lagging behind, as shown that only 86% of this population that are living with HIV are aware of their HIV status. And out of these that are aware of their HIV status, only 89% are currently on ART. And out of those that are on ART, only 81% of the adolescents and young people have achieved viral suppression. And this again makes the program work, because we know that for those that have achieved viral suppression, more so undetectable viral load may not transmit infection through sexual route. This translates into you as equal to you. Next. Okay, so looking at all the information, the background that we have shared so far, and looking at the risks that the adolescents and young people have in terms of acquisition of HIV because of various reasons that we have shared, the Ministry of Health, of course, the Zambian government decided to conduct an Indaba, as Dr. Tina mentioned. This calls for stakeholders to brainstorm in terms of what could be done to reduce the rate of new infections among the adolescent girls and young women, as we earlier noted that about 8% of the new infections come from the adolescents and young people. So what were the objectives of these Indabas? I must mention that we had a number of Indabas that Lucy will take us through. However, they had some overlapping objectives. So one of them was to strengthen and amplify the voices and also the technical capacity of the adolescents and young people to actually meaningfully engage them in the HIV program, and also sexual and reproductive health policies that affect their health and rights. Further, it was to build a supportive and a consultative HIV and sexual and reproductive health advocacy process that reaches and includes more adolescents and young people at the community level. In addition, the Indaba was called for the ministry or for the program to harness, as we are aware that many of these adolescents and young people have got a number of innovations. So we wanted to see how we can harness some of these innovations and indeed some of the best practices among the adolescent groups and also young people towards both the sexual and reproductive health program and the HIV response. We also wanted to develop a young people's action plan that stipulates their role and participation in addressing their HIV and sexual and reproductive health needs and priorities. So there were other sub or specific objectives based on the specific Indabas that were conducted, but these are sort of like overall objectives for each of all these Indabas that we conducted as a country. And just to take the team in terms of what processes were involved. So I'll speak to one of the major Indaba that occurred in 2021, which was also looking at the adolescent HIV SAGE. So the Ministry of Health took lead in the organization of these Indabas. So a task team was constituted, which was composed of various stakeholders that are involved in the provision of sexual and reproductive health for the adolescents and young people, and indeed those players that are involved in the provision of services that are HIV related for the adolescents and young people. So this included implementing partners, funders, UN families, and also civil society organizations and the provincial health offices. So a number of meetings were held prior to the actual day, where a FASTA project, which was under the CRS, was the Secretariat, and I must mention it was the main funder. So the approach was to have it in terms of hybrid, both virtual and physical. And these participants, mainly the adolescents, that was the target groups from the provinces, were supported by various implementing partners and provincial health offices. But at central level, in terms of the main host for the Indaba FASTA project for the national HIV and SAGE Indaba that I'm talking about, supported the conference and other issues that were involved. So basically, it was a multi-sectoral collaboration and also some aligned ministries for this main Indaba to succeed. I thought I should mention to the network in terms of what exactly was involved. So even in the write-up of the reports and everything, FASTA project, which was the main secretariat, did support the Ministry of Health. I think this should be my last slide. Is there another slide that I need? Okay, thank you for your attention. Over to the chair.
Okay, so thank you so much, Dr. Piri, for that background on the Adolescent Indabas. And you did share quite some important information about why Zambia went through that route in terms of coming up with the Indabas as an intervention to make sure that we have more adolescents focused on HIV prevention. So you did mention that Zambia has got a high HIV incidence, making up about 38% of all new HIV infections, and that some of the reasons that were brought out include issues to do with limited testing amongst the adolescents, inadequate comprehension of knowledge comprehension of HIV and HIV prevention, low perceived risk, unprotected sex, limited access to HIV and SRH, and other high impact interventions. And as objectives of the Adolescent Indaba, you did mention that it's supposed to support amplifying of the voices of the adolescents, having HIV and SRH advocacy, harnessing innovations and best practices, and also developing a young people's action plan. So maybe now we can move on to Mercy, who's going to share with us the actual Indabas that have been implemented in Zambia. Thank you. Mercy?
Thank you so much, Dr. Tina, and good afternoon, everyone. My name is Louis Mercy Katoka, and I'm an SSLN HYW champion here in Zambia. But I'm also the country youth representative on the Mosaic project. And just like Dr. Tina has highlighted, I'm going to take us through the past 3 Indabas that we've had here in Zambia. Next slide, please. So the first Indaba is the Adolescent Health Surge. And the surge was actually hosted by the Ministry of Health in 2021, and it did attract a total of 1,563 participants, which just highlights the significance and interest of engagement even from the community. And this Indaba was conducted at the point when we were in the COVID pandemic, and it was a hybrid meeting which just allowed for broader participation, but also it did accommodate those who could only join virtually. And we had participation from adolescents and youth-friendly spaces, both at community as well as facility level across the country. And the surge just provided the platform for young people to meet and interact, as well as share knowledge and just learn from their peers, as well as experts even in this field. And during the surge, best practices as well as lessons were also shared, as well as synergies were shared just to ensure that objectives were achieved. Next slide, please. So this slide just gives us an overview of who the participants were. So we did have adolescents and young people that did participate even in the search. We had a total of 771 adolescents and young people. And we also had representation from the private sector. We had 4 people from the private sector, as well as 16 people who were representing the academia. And we also had representation from the health services. We had a total of 552, and international organizations as well. We had a total of 114, and then we also had representation from legal services. The media was also on board, and also taking into consideration the religious as well as the traditional leaders. So we had that group as well. We had a total of 10, and we also did have partner sister ministries like the Ministry of Gender, and we also had representation from social services, and we also did have local government in attendance. We had the town councils, and also we did have international attendees. So we had people from Malaysia and Mauritius, as well as Nigeria, India, as well as the Philippines. So the attendance was comprehensive, and it did encompass each and every key player, even in this field. Next slide, please. And the second Indaba that we had was the activation session, which was held in 2022 in July. And it was a youth-focused activation session for HIV prevention. And it was held just to respond to the high HIV rates among adolescent girls and young women, just like Dr. Chimika did highlight in the slides that he presented. And this was a 3-day meeting that just focused on 3 main challenges, which were sexual and reproductive health programming. And we also looked at engagement of the young people, and also not forgetting that there are a lot of key influencers around young people. So we also had their parents as well as caregivers. And the goal and overall objective was just to identify established practices for adaptation of existing programs, as well as interventions, so that we can improve the youth and parent or caregiver engagement for HIV prevention here in Zambia, but also to just concur on the context of adolescent girls and young women and their parent communication around HIV prevention. So fostering communication between adolescents and young people and young women, as well as their parents and caregivers, even around HIV prevention. And we also just looked at reviewing of HIV prevention and the sector models that target adolescent girls and young women, as well as the models that also target their parents and caregivers, both nationally as well as the region at large. And this was collaborative effort, and the overall goal was just to determine best practices so that we can be guided even as we are going about our programming here in Zambia. And parents as well as caregivers, like I earlier said, were identified as key influencers of AGYW. And the focus was on changing the incorrect beliefs about sexual reproductive health, as well as communication, and equipping the parents for them to be able to just discuss matters of HIV and sexual reproductive health with their adolescent girls and young women. And some of the recommendations did include the need to involve adolescents and young people, even in the program and design, like from inception, and also engaging community leaders through the use of third-party coaches for parents, and also focusing on collective benefits for HIV prevention. Next slide, please. And so when you look at the participants of the activation session, we did have the adolescent girls and young women key influencers as the primary participants. And we all know that for adolescent girls and young women, these key influencers include parents, they include male partners as well as peers. But for this particular activation session, we did focus on parents and caregivers, and another one was conducted where we focused on male partners. And we also just had other key stakeholders who comprised of adolescents and young people themselves from all the 10 provinces of the country, because of course, nothing for us without us. So the young people were in the room as well. And we also had religious and traditional leaders, traditional healers as well, and also members of the civil society organizations and implementing partners, as well as the Ministry of Health and the National AIDS Council. And young people were not just engaged as participants, but we were actually engaged from inception as part of the planning process, and we did take lead in facilitating some of the sessions during the activation session. Next slide, please. And the third Indaba is the RAHAI, the Regional Adolescent Health Indaba. And this is an Indaba that takes place every year, once every year. And just to give a background context to the RAHAI, we first started with the district adolescent health indabas that were called the DAHAIs. Then we later transitioned to the provincial adolescent health indabas that were called the PAHAIs. And later we had the first national adolescent health indaba, which was the NAHAI, and that was in 2019. And in the year 2020, we actually had our first regional adolescent health indaba, which included the Southern and Eastern African regional countries. And last year, the regional adolescent health indaba did attract a total of 572 participants from across Zambia, but also African countries, which included Kenya. Zimbabwe was also in attendance. We also had Botswana as well as Namibia. And this was a hybrid event where we saw groups of young people brought together at central points, even in specific districts that were facilitated by the district health officers virtually. And we also just had young people who took up the roles of facilitation. So this was young people focused, it was young people led, and young people did come up with a position paper that was later submitted to the Ministry of Health as well as other key stakeholders. Next slide, please. So in addition, live proceedings of the RAHAI were also broadcast on various social media platforms. So the RAHAI was broadcast on the official Ministry of Health page. And then we also had RAHAI being broadcasted on implementing partner pages as well as other key stakeholders. So it had wide coverage, and young people that couldn't attend physically had the chance to attend virtually and just follow the live proceedings virtually. And apart from RAHAI, apart from young people, RAHAI also had representation from senior officials. So we had representation from UN agencies, we had donor agencies, PEPFAR was on board, USAID was on board. We had research as well as academia. We had youth institutions. We had our youth networks. We also had young people in universities that did attend the RAHAI, and we had youth-led organizations and other key players in adolescent health. And we also had the Honorable Minister of Health present, and she did open, officiate, as well as grace the event. So this is just a picture that shows the Minister of Health interacting with adolescents and young people at the 2023 RAHAI during the exhibition. Next slide, please. So when it comes to some of the key achievements from the past three Indabas, so we've actually seen that young people have been included even in national technical working groups, as well as provincial and district level technical working groups. So I'll give an example. For the Adolescent Health Technical Working Group, we have a total of 10 young people that have been added as part of the ADH-TWG, and they do attend all the TWGs that are held by the Adolescent Health Unit at the Ministry of Health. And young people have been meaningfully participating in these TWGs, but then not only at national level, but also at provincial as well as district level, like I earlier highlighted. But then we've also seen that the Families Matter and RISE models, which stratify curricula and materials by child age, are now being implemented through the DREAMS programs and also the similar youth-friendly spaces. And we've also seen that health facilities are now inclusive of peer trainers. So we have peer trainers that sit at health facilities, both for parents as well as young people. And there's also peer learnings that do take place. And we've also seen that the parent-focused activities and interventions now use data regarding HIV and pregnancy rates among adolescents and young people to just provide the rationale to the parents and caregivers for engaging adolescents in sexual reproductive health, as well as HIV prevention discussions. And we've also just seen that MOH, as well as the civil society organizations and other implementing partners, are now including well-established program practices. So there has been translation of materials into local languages, translation of materials into Braille for our adolescents and young people that are disabled, and also identifying of non-financial motivators for sustainability of parent-youth models. And given the age of consent push, that's currently a big thing, a new and an acceptable face by stakeholders from the age of consent to the age of access to health services has also been established. And the age of consent is also another focus area that we intend to look at for the Regional Adolescent Health Indabas 2024 that will take place in May this year. And there's also just been an inclusion of adolescents and young people in HIV and SRR designs and program at different levels. So young people are no longer just being included or consulted, but then young people are being included from inception. So from the design of the programs all the way to the implementation, we've seen that young people are being meaningfully engaged and not just looking at a system of tokenism. And we have also just seen an expansion. So there has been expanded and pronounced adolescent and young people-driven youth-friendly health spaces. And these are actually formerly known as the youth-friendly corners. So we've seen that expansion of the youth-friendly corners or youth-friendly spaces has also taken place. Next slide, please. So when it comes to some of the challenges faced, the first challenge is towards stigma and discrimination that young people face. So most young people that seek sexual as well as reproductive health services or information often encounter stigma from peers, stigma from the providers, and stigma even from their own community, their family members. So there is a whole judgmental attitude, which has really been a challenge. And there's also been low awareness of HIV status amongst adolescents and young people. And currently only 73% of adolescents and young people in Zambia know their HIV status. And we all know that by virtue of one knowing their HIV status, it just gives them a whole different perspective towards HIV prevention and them getting to seek SRHR as well as HIV prevention services in general. But then also issues of availability of commodity. So sometimes there are stockouts on essential sexual reproductive health commodities, and these actually include stockouts on emergency pills, on injectables, and sometimes even condoms in school clinics as well as facilities. And there hasn't really been consistent supply and information on correct usage, as well as vital to prevent unintended pregnancies amongst adolescents and young people, but then also the prevention of sexually transmitted infections and some unsafe practices that young people tend to engage in. Next slide, please. So during the Regional Adolescent Health Indaba, we did have a chance to just present some of these challenges to the Honorable Minister of Health. And this slide just shows a young person explaining some of the challenges encountered to the Minister of Health during the Regional Adolescent Health Indaba. And some of these challenges were with regards to youth-friendly spaces, there being a need to scale up the provision of youth-friendly services within higher learning institutions, and this just also encompasses issues of confidentiality, as well as availability of commodities, and just having well-trained service providers. And there's also challenges with accessing adolescent HIV, sexual and reproductive health services. And this is mostly due to the age of consent, the age restriction policy, where adolescents that are less than 16 years old have challenges or there are barriers to them accessing SRHR as well as HIV services. But then overall, I think it is essential to just reframe the language from the age of consent to the age of access. And this is something that most young people have resonated with, and just having an emphasis that young people's rights to sexual and reproductive health services is vital. Next slide, please. So when it comes to the lessons learned from the Indabas that we've had here in Zambia, one of the things that we've learned is issues of confidentiality and privacy are very key because they actually help to improve services, and they contribute to adolescents and young people wanting to access these services. So there is a need to improve confidentiality in school clinics by just providing adequate facilities that ensure that privacy during consultation is given, and just ensuring that service providers are well trained as well as equipped in delivering youth-friendly services, and also creating a safe space and a space that is supportive for students as well as young people in general. And another lesson learned is on the need for collaboration and referral systems. So there is need to just strengthen collaboration between higher learning institutions as well as external health providers, but then also strengthening collaboration between the different ministries. So for instance, strengthening the collaboration between the Ministry of Education and the Ministry of Health, and establishing referral systems for specialized services that may not be available even within the institutions, just to ensure that students are receiving a comprehensive care package. Next slide. So in terms of next steps, as a country, we want to scale up community interventions for adolescent health, just to ensure that services and advocacy reach all levels and all adolescents in all areas and in all provinces of the country as well as districts. So there is need to just scale up engagements for adolescents and young people, and not only reduce HIV and STI infections, but also ensure that nobody is left behind. And there's also a need for us to just look at the age of access. So the Ministry of Health would probably develop guidelines that would aid easy access to HIV testing as well as counseling services, just to accommodate adolescents that may have difficulties in accessing the services in the spirit of leaving no one behind. So probably having the age of access revised and removing some of these barriers that might prevent adolescents and young people from accessing services. And also just ensuring that total involvement of the clergy and traditional leaders in adolescent health programming is promoted across health information and services at the community level, because you would agree with me that the clergy, the religious leaders, as well as the traditional leaders also do play a key role even when it comes to adolescents and young people making their decisions with regards to their health. And in addition, there's also, as the next step, the need to prioritize the improvement of supply chains, just to ensure that the issues of stock out are being prevented. And this will also just ensure that facilities are adequately stocked with essential commodities that adolescents would need to help them prevent STIs, unintended pregnancies, as well as HIV. And also the use of the Constituency Development Fund, CDF, to facilitate community-driven HIV prevention. So probably allocating a percentage of the CDF towards adolescents and young people community-driven prevention interventions, and bringing on board the media as well. So media engagement featuring on national broadcasting, television, and also just looking at the IEC materials that we have, developing them in line with the agreed interventions by the delegates at the Indabas, and also ensuring that these IEC materials are accessible to all young people, and having them translated even into Braille for adolescents and young people that are visually impaired. And lastly, a continued tracking of key indicators that speak to HIV infection among adolescent girls and young women. So having a tracking system just to assess the outcomes of HIV prevention interventions that target adolescents and young women in the country. Next slide, please. Okay, so this was the presentation that we had for you from the Zambia team. I'll now hand over to Dr. Tina Chisenga. Thanks.
Okay, so thank you so much, Mercy. I think that was a very informative presentation. You did take us through the different types of Indabas that the country has implemented over the years, starting with the Adolescent Health Surge in 2021, the HIV prevention activation sessions, as well as the Regional Health Adolescent Indabas of 2023. So you also highlighted some of the achievements, and these are in line with some of the objectives of the Indabas, as was shared by Dr. Piri earlier. And you've also highlighted some challenges that were shared by the young people during these particular Indabas in accessing services. You've shared some lessons learned from the different Indabas and also some next steps. I think this is now time for us to have a bit of a discussion, and I'll ask Madam Rita Kalamatila to take us through the Q&A and the discussion. Over to you, Rita.
Thank you so much, Dr. Chisenga, and good afternoon, everyone. My name is Rita Kalamatila. I work for the National AIDS Council here in Zambia. And let me also say thank you for still being around on the platform to listen to what Zambia had to share this afternoon. So now we are in a session where we get to have questions answered by the country team presenting. We also will look at any comments and any clarity that you may so wish to ask the country that was presenting. So do we have any questions? I can't see right now any hands that have been raised. So perhaps I think I'll start with some questions in the chat. I have a question from Kerry, and the question reads, the achievements of the Indabas are impressive. Are the proceedings of the Indabas captured? And who is accountable for making sure that decisions and recommendations are let me see. Who is accountable for making sure that decisions and recommendations are implemented? So I'll ask our chair, Dr. Tsenga, to respond to this question, and then we'll have other champions also add into what you'll share. Over to you, Chair.
Okay, so thank you so much for that question. Very important question. Yes, our primary objective of having the Indabas was for us to capture all that information, that rich information that was coming from the adolescents themselves, so that we enrich our programming. So maybe I'll give an example of the first surge that saw a total of 1,563 participants from across the country. From that Adolescent Health Indaba, what we did is we came up with what we called the Adolescent HIV Surge. And what this entailed was that we were going to enhance or increase services for adolescent HIV adolescent services within particular districts that have a very high incidence or have adolescents who are at high risk of contracting HIV. And these districts are 48 across our country. We have a total of 116 districts in Zambia, but those where we have highlighted the highest incidence of HIV infection amongst the adolescents are 48, based on the Naomi information that UNAIDS has done across the different countries. So we came up with specific indicators that we were going to track based on the interventions that we were going to come up with that would help us improve the services in those particular districts with the high incidence. And after a period of 2 years, we did review the information or the data based on the indicators that we were tracking after implementing the interventions or the suggestions that had come from that particular adolescent Indaba. And we did see some market improvements in the districts. Of course, we're yet to look at how that has affected the incidence in those particular districts, but that's something that we've done in terms of information coming from these Indabas. I hope I've answered your question. Over.
Thank you, Dr. Tsenga. Mabel, I can see that Mabel is also on call. Mabel is one of the champions here in Zambia, and she also works for the Ministry of Health in the Adolescent Health Unit. Mabel, do you want to add anything on what Dr. Tsenga has so far shared?
Good afternoon, everyone. Thank you to the presenters. Nothing really much to add, but just I think the other part of the question was who is accountable. So the program officers in the Ministry of Health, as well as the stakeholders, the partners that we're working with to hold these Indabas are accountable to ensure that the resolutions that come out of them are implemented accordingly. Thank you.
Okay, thank you very much, Mabel. I'll read another question, and this question is from Anna Katengule. Anna says, great presentation. Thank you, Anna. There's been a mention of school clinics. Are these in every or most schools? It was also mentioned that the faith sector has been involved in the Indabas. How are things going at religious affiliated schools in terms of access to HIV prevention commodities? Mabel, please, over to you.
Would you come again? My connectivity is a bit bad, so I've been dropping in and out.
Okay,
Would you
so
repeat the question? Yeah.
yes, so there's a question from Anna. Anna says, good presentation. There has been a mention of school clinics. Are these in every or most of schools? It was also mentioned that the faith sector has been involved in the Indabas. How are things going at religious affiliated schools in terms of access to HIV prevention commodities? I think this was mentioned in the presentation by Macy in terms of the stakeholders who attended these meetings. And among them, we had members of the religious section, the clergy, and we also have members from faith-based organizations, as well as the traditional leaders themselves. So this question is being derived from that end. Over to you.
Okay, thank you. So not all schools have clinics in them. There are some schools where we have health facilities as well as adolescent and youth-friendly spaces. As in regards to health services in the faith-based institutions, there are limited services that can be offered in the religious-based institutions. So information can be given in terms of comprehensive sexuality education and life skills. You can offer health information in all schools, but when it comes to services, for instance, contraceptives, they cannot be offered in a faith-based school, as well as even a general school. So you do referrals to the health facilities. We have healthcare providers who would visit schools, offer information, or set up outreach points just very close to the school so that learners would walk from their school premises to that particular place to access services. Over to you.
Thank you so much, Mabel. Dr. Chimika, anything you'd want to add on?
Yes, thank you, Chair. So just to add on in terms of the response from the religious sector, we have seen an increased interest in terms of participation in HIV and other health-related activities, particularly if I can speak for the northern region, in particular Copper Belt, where we've seen a number of churches offering space for Ministry of Health to put up health posts. So if you go, for example, in Copper Belt provinces, most of the community health posts are actually within the grounds of the church. And I think that is testimony enough to show the support that the religious sector is providing to provision of health services. So these health posts are actually providing various health services, including sexual and reproductive health for the adolescents and young people and HIV-related activities. I thought I should add to that. I submit. Thank you.
Thank you, Dr. Chimika. So I still don't have any hands, but I have some messages in the chat box. And the next message is from Blessings Muzumara. Blessing says, what efforts are you putting in as Ministry of Health to involve and engage young people from all 10 provinces in the technical working groups? So I'll have Dr. Tsenga and Mabel respond to this question. So I'll start with Dr. Tsenga. Chair.
So Mabel maybe would be the best to answer this one because she takes care of the adolescent health services. But maybe just to mention is that we are as a ministry trying to decentralize the services that are being rendered across the country. And we do have specific teams within the provinces and the districts that look at the services within the districts and the provinces themselves. But I'll ask Mabel to really speak to this in terms of the efforts that we're putting in place. Over.
Okay, thank you, Chair. So every technical working group, starting from national level to sub-national level, is operating under specific terms of references. The TOR as well, we've prescribed that every technical working group should have a certain number of young people represented. So by that guideline, all districts or provincial technical working groups are supposed to have representation of young people. So that is the measure that the ministry has put in place, and that is being abided to unless otherwise in specific isolated issues. But that is the measure which is in there. The TORs stipulate clearly the number of young people that are supposed to be represented in each technical working group. Over to you, Rita.
Okay, thank you so much, Mabel. So before I could read any messages, we do have a hand from, I can't pronounce this name very well, but it's, is it? I think go ahead. It's Tambua, something like that.
Oui,
Go ahead.
vous m'entendez? Allô, vous m'entendez?
Oui, continuez. Allez-y.
Ah oui, je suis Madame Tamboué Medine du Congo-Brazzaville. Je voudrais savoir, je remercie d'abord les présentateurs, vraiment c'était une présentation riche, mais je voudrais savoir comment on fait avec les jeunes qui sont dans des maisons pénitentiaires, puisque chez nous ici, par exemple, il y a des mesures de prévention comme les préservatifs n'ont pas, qu'on ne peut pas avoir accès dans des maisons pénitentiaires. Maintenant, pour eux, pour assurer la prévention de ces jeunes-là qui sont dans des maisons pénitentiaires, qu'est-ce qu'on fait, qu'est-ce qu'on a pris comme mesure, qu'est-ce qu'on fait pour atteindre en fait cette jeunesse-là? Voilà ma question. Allô?
All right, thank you hello, thank you so much for that question. Dr. Chimika, would you like to take on this question?
Thank you. I missed the first part, but I believe the question is in terms of the interventions for the juveniles that are incarcerated, in terms of access to condoms in specific. So I will answer part, maybe Dr. Sanga can as well add. So under the key population program that focuses in terms of provision of HIV prevention services, like in Zambia, for the juvenile prisons, the way they live is slightly different from the adult prisons, because for them, it's more of a rehabilitation and a sort of open prison where they are free to move around within the premises, and also there's a facility within the parameter of the prison. So that facility is run by government, and it provides all health services from curative to prevention. So this prevention includes HIV preventions where they're able to offer and make available condoms. So that's what has been put in place. So it's slightly different from the adult prisons where they are really restricted, but for the juvenile, sort of an open prison where they can move around freely and access these services from the health facility, which is within the premises of the open prison. Maybe Dr. Senga, do you want to add something?
So maybe I just wanted to make mention that we also face a similar challenge, as you have mentioned, our colleague from Congo Brazzaville.
when it comes to services being provided within the prisons, particularly for prevention. But what we've done is that we've come up with modalities of ensuring that prevention services are available, particularly for those who are about to be released. So they do have this time where they kind of have open hours where they can go into the community and come back. So those ones, it's possible to have prevention services availed to them. But again, I just need to make mention that we do also face a similar challenge when it comes to services, HIV prevention services within the prisons. Thank you. And willing to learn from those who don't have that kind of challenge.
Yeah, can I add something as well?
Please go ahead.
Yes, so in addition to the 2 submissions that have been made, we also train the juvenile young people that are in our correctional institutions as peer educators. So we train them in peer education, which covers a whole range of comprehensive services for adolescents, including HIV prevention, STI, condom use, and the like, who work with the facilities that are within the premises. So they easily get to provide services to each other in terms of condom distribution. I submit you.
Thank you so much, Mabel. I have noted that Dr. Vupe is also on call. Dr. Vupe, any comments?
No, none from me. Thank you.
Thank you so much. I have another question in the chat, and it's in French. I think I'll need help for this question. It's from Boris. How can I get the question translated, or should I ask somebody to read it on my behalf?
Rita, it's been translated. I don't know if you've seen the translation.
Oh, let me see it.
I can read the translation.
Yes, please read for me, Doc.
It says, hello, I'm Fayol from Congo Brazzaville. My question is, what strategy has been put in place to maximize awareness among adolescent girls and young women in and out of school? Is HIV part of the school curriculum for young girls in school?
Okay. Thank you very much, Dr. Tsenga. I was hoping to see someone from the Ministry of Education, like Akim Kanyika or Charity, but suffice to say that we still have an able team on the call right now. I'll let Mabel start responding to this question, and then Dr. Tsenga, you can come back. Mabel, over to you.
Okay, thank you. Yeah, so we are using various social behavior and change communication strategies to raise awareness among adolescent girls and young women, both in and out of school, as well as adolescent boys and young men. So we use the peer education sessions where young people meet in a club format, either on a weekly or bi-weekly basis, and they're taken through different sessions to do with HIV, sexual reproductive health, gender-based violence, and other life skills topics that they're given. We also develop information and education materials, either in print form. We also have information on radios, like radio discussions, the use of social media, Facebook pages by different youth-friendly spaces that are being run in our different health facilities, as well as by stakeholders. So for in school, yes, HIV is part of the school curriculum. It is integrated in specific subjects like civic education, social studies, and science, starting from grade 5 at primary school to all the way to grade 12. So it is age appropriate. And this is part of the comprehensive sexuality education that is undergoing revision right now, and probably the title will change to Life Skills and Health Education. So yes, it is part of the school curriculum. I submit.
In addition, from Dr. Chimika or Dr. Chisenga and Featherstone, you also on call, you're free to add.
Nothing from me.
No addition from me. Thank you.
All right, then we'll go into the next question. And the question reads, it looks like the Minister of Health is very committed to adolescent health. I'm wondering if other ministries have similarly high political commitment and leadership for HIV prevention for adolescents. And if so, are there lessons that you can share with other countries on how to secure and build leadership at this level? Dr. Chimika.
I think I'll let Dr. Chisenga respond to this.
So let me just break down the question. So yes, the Minister of Health puts adolescent health paramount in terms of one of her focus areas. And this is stemming from the fact that as a population, Zambia has got the highest population for the Zambians is those below the age of 35. So of course, most of the interventions when it comes to health are targeting the young people. And if you look at the different issues that are surrounding health, they are specifically targeting the young people. So we do have great political will when it comes to Ministry of Health. And I do believe that this is not just for Ministry of Health alone, but as a country as well, because of the same reason that I've shared, the way the pyramid, the population pyramid is, our country is mostly of young people. How do we, what was the other part of the question? How do you engage, what is it? And if so, are there lessons you can share with other countries on how to secure and build leadership at this level? I think the major one is for them to understand the issues that are surrounding health and how these can be mitigated. What we've learned is that once the leadership within the ministry understands the background of the problem that is being experienced within a country, it makes it very easier to build support at the level of minister as well as of president. I'll make mention that I think I don't know which year it was, but we did have an Adolescent Health Indabas that was actually graced by the President of the Republic of Zambia. Just by that virtue, you know that there is a specific interest within the political leadership. So understanding making sure that the leadership understands the background of the health problem is really key to getting that support at all levels. Maybe Mabel can join in to show what other ministries are doing in terms of political commitment. We do have a specific ministry that looks at the youth. So obviously that's something that the government has done to bring a focus amongst the youth. Of course, our education has really taken a turn into making sure that the health aspects of those learners within schools are taken care of. But Mabel can make mention of how the political commitment is in the other ministries because she works with the other ministries. Over.
Okay, thank you, Dr. Chisenga. Yeah, so like you have mentioned, I'll take it up from the last point where you mentioned Ministry of Youth, Sport and Arts. So the easy way of getting political involvement and leadership in adolescent health is actually, it starts from the policies that the government of Zambia has. The Healthy in All policies encompasses that every ministry incorporates the health aspect of it in their strategies, in their policies. And so starting with that, the Ministry of Youth yes, looks at youth issues and holistically, mainly sports and empowerment, but they have incorporated a healthy aspect of it, which is very strong. And this is where we derived our CSC for out of school curriculum. It is actually being housed by the Ministry of Youth, as much as Ministry of Health is using it in terms of dissemination of information to the young people. And so it starts from that aspect. So you find that the Ministry of Health, the Ministry of Youth, as well as the Ministry of Education are highly involved as well, and indeed interested in the health and well-being of their young people. So like we are celebrating Youth Day next week, and there will be another Indaba which will be graced by the President. And that's Indaba in the celebration of the Youth Day will equally be heavily covered by health issues that will be discussed in that particular Indaba. So it's the incorporation of health in all policies, the incorporation of health in all different ministries that are working within the country and looking at the well-being of the young people. When it comes to Ministry of Education, and this is why it is part of the curriculum, HIV is part of the curriculum, and the different more diseases that are covered in the school curriculum. It is also to ensure to get the buy-in of all political leaders. So we have what they would call healthy days in schools. And that was approved by the Minister of Education. So we have a memorandum of understanding between Ministry of Health and Ministry of Education in terms of provision of health services in schools. We use the schools as a platform for service delivery just outside HIV, the use of mass drug administration in terms of those neglected tropical diseases. We use school platforms to deliver those health services. And so the political will is really high. So it starts from the multi-sectoral coordination. With us, we are calling it the National Adolescent Health Technical Working Group, where we have all these key line ministries. And so we collaborate from that aspect. We have our permanent secretaries communicating via writing on each platforms where we need each and every one of them to be part of it. So start with that small coordination, multi-sectoral aspect, get all the line ministries and get your people start talking. And then it's very easy to involve the political players at high level via the respective ministries, as long as they are working together through the technical working groups. I submit, Chair.
Thank you very much. So I hope that the question has adequately been answered. So in short, what Mabel was saying that there is the HIV and AIDS response in Zambia is multi-sectorial. Multi-sectorial. So Ministry of Health works with other ministries like the Ministry of Education, Ministry of Youth and Sport, Ministry of Community Development and Social Welfare and others. So like she has rightly put it, each ministry has put in place a workplace policy or what is called a health and wellness policy. So from there, I think I have two other questions that have been posted. And the first one reads, I'm not sure if this has already been asked, but does Zambia have targeted programming for street connected or homeless AGYW? If yes, how is this done? Dr.
Rita, I could take that one.
Yes.
If that's okay.
Yes, Dr. Tsenga, please go ahead. Oh, yes, Dr. Bupe, go ahead.
Whilst we do have some small programs through the Ministry of Community Development and Social Welfare, which I think Dr. Tina can speak to from the government side, I do know that under the support of the USAID, there is a program called ECAP, which is basically trying to empowering orphans and vulnerable children in the community, specifically providing support to those vulnerable families, especially those who've been affected by HIV. So some of the work that they do is door-to-door counseling and door-to-door testing, community testing, linking them to care by providing even transport, meeting the transport costs and any other things. and even actually doing viral load testing right there in the communities and querying the samples. They, because we've had feedback from the community about some people, it's not that they don't want to go, they have no time to go. So some of the things they do is they do offer time or service for time missed for people at work. So like for the men, if he said I had to make some money doing some odd job, they'll compensate him for that so that he can go support his family. I already mentioned the transport costs and even doing enhanced advanced counseling for those who have fallen off care due to various reasons. So basically it's a project that is in most of the provinces that is trying to basically offer support to orphans and vulnerable children. Of course, this has not been brought up to scale, but at least it's one of the few projects that is offering these services. On the part of social welfare, Dr. Tina can add more details, but I do know we do have a social cash transfer system that offers support for vulnerable families. Over.
Thank you very much, Dr. Msonda. Dr. Tina, do you want to add anything?
Yeah, so just to mention that to acknowledge that this is really a problem, even for us in Zambia. I think the biggest one, if you look at it, yes, we have the vulnerable children who may be orphaned but have family. Those are easier to get to, but the ones on the street, especially the adolescents, it's very difficult for them to get them connected or even to give them support because they still go back onto the street. So I want to firstly acknowledge that this is really a problem within Zambia as well. And we're looking at different measures like Dr. Msonda has mentioned, measures that are working and if those can be brought to scale. Of course, the social cash transfer supports those who may be vulnerable and orphaned, but we are looking at ways to also have support go for those who are homeless or even on the street. Mabel, I don't know if you've got specific experience on this that you can speak to.
Not quite. Of course, we do have our healthcare providers, particularly for Lusaka, who does occasional outreach services. They would take the services nearby. For instance, we have street adolescents around Kamwala area. So they would pitch at government complex thereabouts and just try to mobilize them. So occasionally they do offer outreach services to them, but it's not something which is at scale and not well planned per se. So, but it's just occasional outreach health services. I submit.
Thank you, Mabel. Featherstone, anything you'd want to add to the submission from Dr. Tsenga, Dr. Msonda, and Mabel?
Yeah, no, nothing, Rita. I think so far the question has been addressed. Thanks.
Okay, thank you so much. I think this looks like a last question I have in the chat box, and it's saying, thank you for the presentation. What are the innovations for AGYWs and ABYM related to retention in receiving SRH services? Featherstone, I'll throw this to you, and then Dr. Msonda can also add.
Sorry, Rita, I missed you. Come once again.
Okay, so the question is asking about innovations. What innovations do we have as a country for AGYWs and ABYM related to retention in receiving SRH services? What innovations do we have in country for AGYWs and ABYM related to retention vis-a-vis SRH services?
Yeah, so thank you so much. That's a very good question. And so really, I think what we have seen over the years, when we look at, I think, the epidemic in Zambia, which of course, I think is more prominent among us, the AGYW. But however, when it comes to programming, what has been done is that we do not leave out the boys. We have realized that a lot of interventions in terms of, having interventions for the girls, the stepping stones. And now we have interventions such as what we are calling the boys to men, where the boys now as well are engaged just to ensure that they also get the teaching, how they can be able to support their partners who are the girls, how they can be able to be role models, how they can be able to be champions, of sexual reproductive health services. So I think an aspect of having an approach where we don't leave the boys behind, I think is one approach which is working very well. And I think as earlier indicated, the various networks within the provinces, the young people now are involved in all the technical working groups at national and sub-national level. I think this in itself is making them to be, I think, part of programming and just to own the process, whatever interventions is put across. Okay, I'll end here, Mabel, and just allow others as well to contribute.
Dr. Msonda, innovations that we have in country.
Thank you, Rita, and thank you, Featherstone. I think just to add on, another intervention that I mentioned earlier was what we're calling the advanced, enhanced adolescent counseling. So what we do is we know that for adolescents, there's challenges in terms of retention in care for various reasons. So this is a type of counseling method that is really just centered on understanding the root cause of these and trying to bring them back into care. So reminding them that HIV isn't a death sentence and that there's life afterwards and everything. So these sessions can go on for like 6 months, just so we can try and retain our adolescents in care. So it's something we're trying to do it's part of the training actually for adolescent HIV, and it's a package that we're trying to really enhance in terms of implementation. So this is just one of the things we're trying to do to encourage them to stay in care. Another intervention that is being explored but not yet implemented is how do we get the ones who are in school, boarding schools and tertiary institutions like universities, how do we get them to stay in care whilst they're away from their facilities? So we have been exploring a lot of interventions, such as maybe pop-up clinics in the universities, for those in boarding schools, nominating the matron to be like the champion or treatment care or buddy provider. So these are small things that are being piloted, and once we're able to see that these will be successful, I'm sure these are things that can be promoted nationally and brought to scale. Over.
Thank you so much. Mabel or Dr. Tina, if you have anything to add on.
Okay, just for the other parts, even just general SRH services, as the question added to HIV, we are also using the peer model, the peer-to-peer support groups that helps young people check on each other, that helps young people stick to adherence timelines as they are guided and encouraged. So the peer-to-peer aspect is also helping young people be retained in treatment and care. So I submit.
Thank you so much. Dr. Chisenga, anything?
Nothing from me. I think everything has been adequately covered. But maybe I'll just direct people to also look at the presentation once it's shared. There were some innovations that were highlighted in the presentation. Thank you.
All right, thank you. So I think this is the last question before I hand over to the chair of the session. So the question reads, thank you for the presentation, colleagues. Are there upcoming Indabas, and what will the focus be? Then secondly, how is the focus of the Indaba chosen? Dr. Chisenga, over to you.
I think Mabel made mention of the upcoming Indaba. Maybe she can expand on it. Mabel?
Okay, thank you. Yeah, so we are having the upcoming Indaba meet this year, I think May, June. July, somewhere there. So the focus is usually informed by the current challenges. So if you look at the presentation, there was a data on how we are faring in terms of the 95-95. So we look at the indicator that is really not performing very well. And that's where the focus will be derived from. And we also inquire from the young people around. We ask them what areas they would want to be addressed. So mainly the focus will be informed by the data as well as consultations from the young people to know. But particularly this year, the focus might be around PrEP because of the same aspect of low viral suppression. If we are to prevent HIV transmissions or new HIV transmissions among young people, we have to combine prevention among the negatives as well as the positives. So with that aspect, this year's focus might be mainly being around PrEP and ART in terms of viral suppression, retention, and care. So I submit, we haven't yet fully agreed, but that is where the focus would be.
All right. Thank you so much. And that was the last question in the chat box, and I don't have any hands that have been raised. So let me say thank you very much, everyone, for this interactive session. And I would also like to thank Team Zambia for addressing all the concerns that have been raised in this particular session. So I'll now hand over to the main chairperson, Dr. Tsenga. Thank you so much.
Okay, so thank you so much. I think that was very interactive. And even as Zambia, we've noticed where the keen interest is from the different participants when it comes to the Adolescent Indabas. So maybe we can quickly, I've seen that there's a poll that has come up. Please go through the poll, but we can have some key takeaways from the different countries that are available. Do we have some key takeaways from Malawi? Malawi?
Yes, we do.
Yes,
Sorry,
please.
I was distracted with the
poll.
Yes.
Okay. Please go ahead with any of your key takeaways.
All right, just a moment. I had two devices, so I need to log out from the other device. I hope that's okay.
Okay, so maybe while you do that, we can move on to South Africa, and then we'll get back to you. South
So
Africa.
I'm already done, if
Okay,
it's okay.
all right. Please go ahead.
Yes. So first of all,
I think we've lost her. Is it just me? Are you there, Malawi?
No, it seems we've lost her.
Okay. So maybe we can move to South Africa while we wait for Malawi to log back in. South Africa? Any
Good day, everyone. My name is Nasisha Mukwena. I am from South Africa. I work for AIDS Foundation South Africa. So some of my key takeaway from this session, I like the components where we actually were speaking about the retention part, because I did note that in South Africa we particularly have a challenge in terms of retaining HYWs into the program. I like the idea of having those closed sessions group, which can stretch over 6 months, to ensure that they have something that or a program that they can attend, and the fact that the inclusion of structured program such as I forgot the one that you mentioned, but we have a similar program, the Boys to Men, and we have a similar program which is One Man Can, that will start rolling it out shortly, which is focusing on SRH information for ABYM. So we would, that integration would look so good for retention as well. I'm just happy to have those conversations with the colleagues here. Thank you.
Thanks, South Africa. Do we have any others from South Africa, or we can move on to Ghana? South Africa, any other? None? We can move on to Ghana. Ghana, are you there?
Yes, I'm here.
Yes. Please go ahead. Any key takeaways?
Good, thank you all. Yes, please. Thank you. I am upon Ejari Derek from the Ghana AIDS Commission. Two key takeaways. The concept of age of access just struck me for the first time after this presentation. It is very, very important, and it's going to help to do away with some of the restrictions that we currently have. But the challenge is that the age of consent has been embedded it has been enshrined in the law. So before Ghana can shift from age of consent to age of access, we need to go back to Parliament, and that can be a tortuous process. But then it's something I'm going to table to management. Takeaway number 2 is the health days. The health days in Zambia. I want to comment Team Gambia. We used to have in schools and out schools in Ghana, but then for lack of funding, we are not doing much in that arena. But having an MOU between Ministry of Education and the Ministry of Health and other line sectors that is happening in Zambia is something that we can go back and we welcome. Thank you very much. Over.
Okay, thank you so much, Ghana. I think those are important contributions. Probably just an appeal to the SSLN team, Secretariat. Maybe we can have a deeper discussion around age of consent, age of access, with lessons learned from a country that has done well in this aspect. Can we have Malawi? I see that she's back. Malawi, please give your takeaways.
Thank you. Sorry, I lost connection. But so we've had similar activities like the Indabas before, what we called them symposia, HYW symposia. But this was done at national level. So from the presentation from Zambia, we have learned that it's also a good approach. They mentioned having some of the Indabas at subnational level. And this is one of the key takeaways because it looks like it's a kind of convention that allows for deeper representation and also to get first-hand insights from the different districts or provinces. And so this kind of enriches the topics that are discussed. Again, the incorporation of parents and caregivers into these dialogues. This is good because recognizing our African context, it's actually essential to address the holistic environment in which the adolescents and young people need to navigate SRHR issues. So whilst we also do have dreams implementing the Family Matters program, I think involving parents and guardians in spaces such as the Indabas would foster a more comprehensive supportive system. And again, another takeaway is leveraging data to substantiate the necessity of having the adolescents engaging in SRH and HIV discussions. So the use of data as presented by Zambia to compel the parents to involve the young people in such discussions is also key. One of the key takeaway points of how we can also include parents and caregivers. So those are some of the takeaway points, but still, I would like to make a plea for all of us in here. There was a question about street-connected children, and I know we all work with the principle of leaving no one behind. The plea is that we all need to consider them, to remember them, As Malawi, we've just started having such discussions, and we've had former street-connected children kind of sharing what happens in the streets, and it's really something we all need to consider. Maybe we can start thinking about how to include them, because at the end of the day, these are the ones who they grow and we now call young KPs. One of the lessons we learned was that most of the street-connected children are boys, and the girls are nowhere to be seen. Now, upon inquiry as to where they are found in the hotspots. They are now what we call young KP, or exploited girls, and then we begin a special programming when we could have caught them earlier on. So it's something that we're also starting to work on, and maybe all of us in the room can consider to work on this as well, and then we continue learning from each other. That's a plea that's coming from the Malawi champions as we also work on it. Thank you.
Thank you so much, Malawi, for your key takeaways. And I think that's a great key takeaway from this whole session, that we really need to see and focus on the street-connected children and come up with interventions that can support them. I think for Zambia, this is well noted. And I'm hoping that one day we'll actually come here together and discuss what countries are doing in this space. Thank you so much, Anna, for that. Last but not the least, can we have Congo share that takeaway?
Ok. Est-ce qu'on m'entend? Bonjour. Tout le monde m'entend,
Yes.
c'est ça?
Please go ahead. Oui.
Ok, merci. Je suis Pachnel Bongo du Congo-Brazzaville. Ce que j'ai retenu de cette session, qu'il y a beaucoup de points qui peuvent nous permettre d'améliorer notre façon de faire dans notre pays. Et tel qu'on a parlé de l'accès aux préservatifs dans les milieux incarcéraux et tout, c'est très instructif, c'est une stratégie que nous n'avons pas. Mais autrefois, nous organisions une activité comme Indabas, comme ça, que nous appelions Freges. Et ce forum regroupait tous les jeunes de la sous-région de la CEMAC. Et au cours de ce forum, nous partageons les activités que nous avons menées, des activités annuelles. Et nous cherchons les points faibles, nous cherchons à les améliorer afin de faire mieux dans les jours à venir. Et aussi, nous avons des magazines pour jeunes. Et on a le magazine 100% Nana qui ne parle essentiellement que de la jeune fille. Nous parlons de santé sexuelle, reproductive, VIH-Sida. Nous avons des émissions radio également, des émissions dédiées aux jeunes que nous diffusions à la radio nationale, une radio qui est suivie dans tout le pays. Nous avons également l'existence des clubs réglo en milieu scolaire. C'est un groupe de jeunes qui se réunissent dans la semaine et autour d'un thème. Et ces groupes-là sont animés par les jeunes. Et au cours d'Indabas, j'ai retenu qu'il y a beaucoup de points que nous devrons améliorer dans mon pays afin de limiter les nouvelles infections en milieu juvénile. Nous avons également Cursivac, c'est une kermesse que nous organisons pendant les grandes vacances. Donc, ces kermesses vacances sans sida. Au cours de cette activité, il y a le dépistage, il y a la sensibilisation, pardon. Donc, il y a toutes ces activités pour permettre aux jeunes d'être à l'abri du danger. J'ai vraiment apprécié cette session. C'était vraiment une belle leçon pour nous. Ça nous permet, en tout cas, comme j'ai dit au début, d'améliorer notre façon de faire. Et je vous remercie. Je remercie tous les représentants, tous ceux qui ont présenté leur travail. En tout cas, merci. Je m'arrête là.
Okay, thank you so much. I think that's really important what you've shared with us. I'm hoping that I wish you all the best in your Indabas, in inverted commas, and maybe one day we can hear from Congo Brazzaville in that aspect. I think this has been a very good session. We have learned quite a lot even as we were presenting. From the questions, we do realize what we need to focus on as a country. And we're hoping that even in the smallest way, we have shared with you something that you can take up as a country to improve the adolescent health services within your countries. I would like to thank all of you for your participation. I would like to thank the presenters for the good job well done. And most importantly, I would like to thank the SSLN Secretariat for bringing us together in this space where we can learn from each other and be able to improve upon the interventions that we're implementing within our countries, and also become more innovative based on the suggestions that are coming from other countries. We do have a lot of work to do within the HIV prevention space. And of course, our young people should never be left behind. And the appeal from Malawi is well noted. And we're hoping that all the countries that have been present here are going to take up that that challenge from Malawi to make sure that our street connected children are looked after. So thank you very much, and I wish you all the best. I hope everybody completed the poll, and until next time, thank you. Bye-bye.